Hello, good morning and welcome everyone to the 14th and last lecture of your oral histology course. We'll be talking about the temporomandibular joint. This is Dr. Siham Al-Arish. I hope you will enjoy this lecture. Firstly, we'll talk about the gross anatomy of the TMJ, and then we'll go into the microscopic histological features of the articular surfaces, intra-articular disc, synovial membrane. We will talk later about the developing condyle, and lastly, an overview of the clinical considerations. So the definition of the temporomandibular joint, it is a synovial articulation between two bones, the mandible and the cranium, and more specifically the temporal bone of the cranium, of the skull. It was previously called the craniomandibular joint also. The synovia is a thick, clear liquid that could be found. It is a type of joint where there is a liquid that helps in moving the bones. This synovial articulation allows for many movements in which the hinge joint movements, which is open, closing, anterior, up and down movement, and the gliding or the translation movement, which is the other directions, also to forward, backward, and extrusion, intrusion, to the lateral and medial movements of the mandible. What is also characteristic about this joint is that the articular surfaces are covered with a fibrous tissue, and it is a center also of cartilage, the intramembranous bone formation. Until the adolescence, the mandible or the condyle is an ossification center, where the cartilage is being ossified into bone under the fibrous surface. Lastly, the joint cavity is divided by a disc called an intra-articular disc. It is divided in two spaces, an upper cavity and a lower cavity. Here we see this articulation between the temporal and the mandible. Most importantly is the articular disc, which separates into a superior and an inferior joint cavity, and all of which are surrounded by an articular capsule. The gross anatomy of the temporomandibular joint. Each of the bones in the upper and lower compartments is covered by a fibrous tissue. We see the articular disc separating into two synovial cavities. The synovial cavity here in which fills the liquid, which is secreted to lubricate, mostly to lubricate the movement of the joint. Now we will start about the gross anatomy. We will talk about the mandibular fossa, the upper articular surface, the mandibular condyle, the lower surface, the surrounding capsule, the temporomandibular ligaments, accessory ligaments, and finally about the articular disc. So the mandibular fossa, it's the oval depression in the temporal bone, which is anterior to the acoustic meatus, external acoustic meatus. There are variations inter-individually in the curvature of this fossa. Can be caused maybe by the occlusion in each person. The intra-articular disc, it molds the shape between the fossa and the condyle. So it adapts with the shape. The mandibular condyle, the lower compartment, also it has a variation in size and shape. The long axis is surely not at right angle with the ramus. So it is convex anteriorly and superiorly, where this surface of the condyle meets the concave articular surface of the mandibular fossa that we talked about. Lastly, it joins the ramus through the neck of the condyle. Here, as we can see, the mandibular fossa posterior to the articular eminence, which is a shallow depression, and the condyle, which is the head of the condyle, is a convex surface, and it joins the mandible through the neck. So in between these two articulation surfaces, we have the articular disc in between an upper and lower synovial cavities. Then we talk about the articular capsule. It's a thin cuff of fibrous tissue that covers the interior and exterior temporomandibular joint. It does not limit the movement because it is too weak to provide any support for the joint. So externally it is attached to the glenoid or the mandibular fossa, the articular eminence, and the neck of the condyle. In the posterior portion, it is associated with the connective tissue of the disc, and from the internal side it is attached to the interarticular disc, and it is lined by the synovial membrane where the fluid will be secreted. It is a richly innervated capsule. The synovial membrane lining the inner surface of the capsule and the disc, it does not cover the articular surfaces, and it secretes the synovial fluid that fills the joint cavities, lubricates the joint, and has a nutritive function. So here we go, the mandibular fossa and the head of the condyle articular surfaces, the intraarticular disc, which is attached posteriorly to the capsular ligaments. We noted that the capsular ligaments are very weak to limit the movement or to make any support. The temporomandibular ligament, or it's called the lateral ligament, this is what strengthens the joint capsule. It is the main ligament that restricts any distal and inferior mandibular movements. It resists also dislocation during the functional movements. It starts in the lateral surface of the articular eminence and is inserted into the posterior surface of the condyle. You see how it helps in the hinge movement or anterior medial movement of the condyle. you have the main lateral or temporomandibular ligament, plus many accessory ligaments, part of which are the stylomandibular ligament from the styloid process to the mandible angle, the sphenomandibular ligament starting from the spine of the sphenoid bone to the lingula in the mandible, the pterygomandibular ligament, which extends from the pterygoid hamulus to the retromolar region of the mandible, and the retinacular ligament from the articular eminence to the fascia of the masseter muscle. Here we can see the main temporomandibular ligament and some accessory sphenomandibular ligament, stylomandibular ligament. Finally, the articular disc, it is a dense fibrous tissue. It has a blood vessel enrichment from the peripheries only, not in the center. The upper surface is concave or convex from anterior-posteriorly, while lower surface is concave to adapt with the shape of the head of the condyle. So posteriorly it's the thickest part, while centrally it is the thinnest. Lateral half is thinner than the medial half. Lateral half where it is limited by no solid boundaries. Again, this is the articular disc. From the extremities, anterior and the posterior portions, it is a fibrous tissue where the collagen fibers run in a anterior-posterior and medial-lateral directions. While in the central portion, as we said, it is the thinnest and runs in contact with the articular surface of the condyle. So the collagen fibers here, they run only anterior-posteriorly in a more, let's say, regular direction and loose arrangement. So the attachments of this articular disc, it merges with the capsule on peripheries. Anteriorly, it is attached by the fibrous bands to the superiorly the anterior margin of the articular eminence, and in the inferior it is attached to the margin of the condyle as seen in the picture. Medially and laterally, as we said, it is attached to the capsule. Posteriorly, they are attached also to the capsule by a bilaminar zone composed of a retrodiscal lamina called superior and inferior lamina. So, as we said, the articular disc regions, posterior, intermediate, and anterior zone, and from the posterior thickest point, it is attached to the capsule by the superior and inferior lamina, while it is attached anteriorly by fibrous bands. To the bony regions. Here we go, the posterior, intermediate, thin zone, and the anterior bands of the articular disc and its attachment to the capsule, fibrous capsule, appearing in green color. Lastly, we talk about the innervation of the TMJ. It is innervated, richly innervated by most prominent branches are the divisions of the trigeminal nerve, the mandibular branch of the trigeminal nerve, which goes into the auriculotemporal, masseteric, and the deep temporal nerves. It has a proprioceptive nerve endings for mastication and also free nerve endings, the nociception. Lastly, we'll go through the histology of each part of the sections that we described. The articular surfaces, which are the head of the condyle, lower compartment, and the upper compartment, the mandibular fossa, we said they are covered by fibrous tissue in the superficial articular, in the superficial layer. The zone, next layer is the cellular zone, where it happens the proliferation and the cell divisions. The third is the fibrocartilaginous layer, where we have cartilage-like cells. And this is an ossification center in the condyle. Fourthly is a calcified cartilage directly covering the bone, the thin, compact trabeculae of the bone. On the other hand, the mandibular fossa, it is also very similar, having these 4 layers, only it is thinner than the condyle. In more details, the lower articular surface of the head of the condyle, from the most superficial layer is the articular zone. We are talking beneath the articular disc and the synovial cavity. Now here is the articular fibrous superficial layer. Here the collagen fibers that are most superficially are parallel fibers, parallel to the surface, while more deeper they run in a perpendicular vertical direction distribution of the collagen fibers. Also, it may contain some elastin fibers. Next zone is the proliferative zone that provides cells to replace cells of the surrounding layers. Next is the fibrocartilaginous zone, where we see some in the calcified cartilage layer, we see some chondrocytes. The fibrocartilaginous zone, we see fibroblast-like cells and chondrocyte-like cells. Next is the calcified cartilage, the area of condylar ossification, and the subarticular bone, compact bone. The upper articular surface, where we have the glenoid fossa or the mandibular fossa. Fossa, it means a shallow depression. So we have is the shallow smooth depression in the temporal bone, looking like a cup. That's why it's called a glenoid fossa. And also the articular eminence, where sometimes we have contacts with the articular disc. So articular disc is beneath, is the most lower after the cavity, synovial cavity. We see the most superficial layer, the articular fibrous zone, the proliferative zone, the fibrocartilaginous zone, and finally it is the temporal bone. Here we don't have an ossification. So we have the temporal bone. As you see, most obviously it is thinner than the lower articular surface. If we want to be more specific, the mandibular fossa, it has a thin fibrocartilage layer and a compact bone, type of bone, while the articular eminence, which is more anterior to it, the elevation of the bone, it is composed of thicker fibrocartilage and spongy trabecular of bone. Concerning the articular disc, or what's called intra-articular disc, it is composed of a fibrous layer of dense collagen and elastin fibers. The fibers run differently. In the center, they are more regular in an anterior-posterior direction and more loosely arranged. In the mediolateral and the anterior and posterior ends or the extremities, the fibers run in a mediolateral and superior-inferior directions. The appearance anteriorly and posteriorly has more of the fibers is more convoluted and more twisted or coiled. On the peripheries, the fibers are circumferentially arranged. Under the polarized microscope, the fibers, collagen fibers, appear more in a crimpy appearance or wavy appearance, like you see here. These crimps are important for the biomechanical properties of the connective tissue, as they provide more resistance to the tension loads that are on the peripheries. So in the peripheries, the circumferential bundles of the collagen are crimped as a characteristic feature. As for the chemical composition of this articular disc, it is mainly composed of collagen type 1, 80%, small traces of collagen type 3, collagen type 2. There are elastin fibers also, and the ground substance, which composes 5% of the dry weight, is of glycoaminoglycans, which is 1/3 dermatan sulfate and 2/3 chondroitin sulfates. Also, there are other traces of other sulfates. These serve to resist the compressive loading because the proteoglycans in the ground substance, they absorb water, thus help in resistance effect. The cell populations, they are more abundant at birth. So in a child articular disc, you see more cells. There are variations between flattened fibroblast-like cells and rounded chondrocyte-like cells. Moderate amounts of endoplasmic reticulum in the cells. We have intermediate filaments, plasma membranes adjacent to the extracellular collagen fibers. In another way, it means that the collagen fibers in the extracellular matrix lie close to the cell membrane. Also, we have fibroblasts or fibrocytes. Are more in the child or the a young age. The fibroblasts, as we said earlier, are active cells concerned in the secretion of the collagen fibers and the ground substance. On the other hand, if cells are less active with less collagen turnover rate or slower turnover rate of collagen, these are to be termed fibrocytes. So, fibrocartilaginous areas are described in the articular disc. They are composed, or they contain round appearance of cells. They are chondrocyte-like. We see reminiscence of cartilage cells in lacunae. It is very close to cartilage cells features. Also, there is collagen type 2 presence, pericellular matrix that contains microfilamentous material. This pericellular matrix is more found in older ages relating to animal studies. So, the cartilage-like cells in these older age discs, have no pericellular capsule at the periphery of the matrix. Chondrocytes, or can be termed fibrochondrocytes, to describe these rounded cells in the articular disc. Lastly, according to the blood vessel nutrition, in the old age articular discs, the bulk of the disc, or the center parts, are avascular. They lost the blood vessels, while the peripheries, they still maintain the blood supply. There's diffusion from the synovial fluid, also that is nutritive. The superior lamella of the posterior part of the disc, the retrodiscal pad, has numerous vascular spaces, and there are changes in the blood flow according to jaw movements. The synovial membrane, it lines the inner surface of the capsule. It does not cover the articular surfaces, had a flat endothelial-like cells, like fibroblasts and macrophage-like cells, on a vascular layer where we see blood vessels. These cells in the superficial layer, they are macrophage or fibroblasts-like, and they have an immune function and a lubrication function. The folds are present at rest, while with increasing age there are increased projections of the cells. The synovial membrane have a great metabolic activity and a high regeneration activity. In the picture we see the uppermost intimal layer and the vascular subintimal layer, where there is loose connective tissue, vascular blood vessels, some muscles and fat cells. This is the deep layer attached to the internal fibrous capsule. The synovial fluid that is secreted by the synovial membrane, it occupies the joint cavities, the upper and the lower. We have around 1 milliliter of fluid in the inferior compartment, while slightly bigger quantity in the superior. It serves for lubrication of the joint, nutrition from the blood vessels, and the proteoglycans. In the hydrostatic pressure at rest, a low pressure, while it gets greatly elevated during function. As to the developing condyle in a child, the secondary condylar cartilage starts at around 10 weeks intrauterine and stays until the second decade, 20 years of age, as a proliferation site. The condyle would be lined in a fibrous tissue that overlies this proliferative layer. As we said, there's endochondral ossification, and cells there form a thin layer, giving fibroblast-like cells to differentiate into chondrocytes. The chondrocytes, they are not present in lacunae or in column form. Knowing that the cellular processes of the fibroblast, these flattened cells in the area, they allow the passage of nutrients from the peripheries to the other regions of the condyle. The layer above the calcified cartilage layer would be a cartilaginous zone of chondrocytes and secondary cartilage formation. It is a proliferation zone in the child condyle. Developmentally, the primary cartilage appears first before the mapping of the future bone that is inverse to the secondary cartilage, where we already have a bone formed in membranes, and later on the secondary cartilage appears. The primary cartilage has an inherent growth potential inversely to the secondary. The primary could have proliferative zones on the side of the central cartilage region, while in the secondary condylar cartilage we have undifferentiated fibroblasts that they undergo proliferation. So also in the primary cartilage we would have more extracellular matrix that is responsible for the cell proliferation. The chondrocytes in the primary cartilage are arranged in columns in the direction of growth, while in the secondary cartilage growth is provided in multiple directions. And this is why the chondrocytes are not aligned in columns. So in brief, the secondary condylar cartilage that is present during childhood undergoes endochondral ossification, which involves the mineralization of this cartilage matrix and the apoptosis of the chondrocytes. Later we would have the role of active osteoblasts, which form the woven compact bone in the later adulthood. Lastly, a very important aspect of the lecture are the clinical considerations. The condylar ankylosis is caused by trauma or infection to the union of the condyle and the fossa, can be unilateral or bilateral, and causes the inability to open the mouth. The dislocation is the inability to close your mouth, caused mainly by displacement anteriorly or posteriorly from weak capsular ligaments. Rheumatoid arthritis or osteoarthritis are the type of diseases that inflammations of the joints. The internal derangement in the disc, there would be a displacement either with anteriorly, displacement of the disc anterior to the condyle, and here we would have no reduction, or we would have a clicking sound, clicking of the joint. Here it would be disc displacement to the posterior position in relation to the condyle. Here we would have a displacement with reduction. A pain, myofascial pain with dysfunction syndrome, causing severe pain in the TMJ and muscle tenderness, and can be associated with sounds, TMJ sounds. Restriction of mandibular movement, degenerative changes, which might cause changes in the disc shape, eventual perforation in the disc, degeneration in the articular surfaces like hypoplasia or hyperplasia or aplasia, Finally, occlusal changes may lead to changes in the TMJ, like the disharmony between the teeth and the TMJ can be a result of clenching and bruxism, which is pressure on the teeth. All these would cause changes in the TMJ. Thank you for your listening. I hope it was clear the macro and microscopic features of the TMJ. Special thanks for the Professor Firas Sulehat also, always. We open the voting for an open lecture live session for your questions. Thank you.